Good morning. So this is Betsy Hirsch, and I am here on the 15th floor of Phillips Wangenstein, along with Michelle Dolan. I think most of you in the room, so to speak, know us. We direct the Cytogenetics laboratory. And what we'd like to do today is to present a view of cytogenetic techniques, the evolution of those techniques, where the field has been, where it's going. Cytogenetics is always being questioned with respect to, are you going to be here? Are we going to be doing cytogenetics in 2010, in 2020, in 2021, et cetera? And we actually would welcome discussion at the end of this presentation about some of our thoughts about where the field is going. So with that, I'm going to start. And again, this evolution is a continuous process. And we can see these different techniques kind of representing the evolution of cytogenetics. The very start was actually looking at chromosomes without bands, and that was even before my time and Michelle's time. George Unis was a member of this faculty who developed actually the banding techniques for high resolution G banding. And so I think we can kind of move on to the banded era. And this is known, G banding in the field, as conventional G banding. I would say that cytogeneticists are very poor at PR. Nobody else would label themselves as having a technique that is conventional. If we were thought about it from a PR standpoint, we probably could have promoted this as a macro array because you can see the entire genome by G banding, and you can identify numerical abnormalities as well as structural abnormalities. And importantly, those structural abnormalities include both balanced rearrangements, meaning when there's a rearrangement of chromosome, but there's no net loss or gain of material, and unbalanced, where the rearrangement leads you to loss or gain of material. And trisomy 21, Down syndrome, you all know it, is a good example of how G-bands is informative in these cases. So the most common way of generating trisomy 21 is by non-disjunction, when you have 3 separate chromosome 21s in the cell. And about 4% of the time, you will actually have trisomy 21 due to a translocation, the one type of recurring translocation in humans, which is a Robertsonian, where 2 acrocentric chromosomes join at the centromere. And because the short arms of both of these acrocentric chromosomes that are involved, 14 and 21, have repetitive sequences, it doesn't matter that you kind of knock them off in the process of creating that translocation. So why is this important? Why do you need to know whether it's non-disjunction or Robertsonian? Down syndrome, the clinical features of a patient who had trisomy 21 due to non-disjunction or Robertsonian are exactly the same. We don't really see any differences there, but the import is for the family. And this is what you have to think about when you think about constitutional genetics or germline, that you're not just interested in the patient, but you're also making some determinations for family members. And so here you can see that in this case, the father had a balanced 1421. You don't have 3 21s, you have only 1 normal 21, and the second 21 is hooked up to the 14. So what happens during meiosis, during spermatogenesis in this case, is that you can get segregation of these chromosomes such that you yield trisomy 21 due to non-disjunction. So it's important to know from a standpoint of counseling with that family. The other thing about G-banding and being able to see the full karyotype is that you can see these rearrangements regardless of which chromosomes are involved. So here you have a rearrangement between chromosome 6 and chromosome 16. And an important kind of point is that almost all the translocations that occur in families, with the exception of the Robertsonians and a few others, are unique to those families. So you really can't just have, for example, a battery of we're going to look for this translocation or that translocation. You really have to be able to look at the whole genome. Conventional cytogenetics is also used, so G-banding, to look at chromosome breakage syndrome. So Fanconi anemia, ataxia, Bloom syndrome, Wartla breakage syndrome, Niemann-Market breakage syndrome. For many of those syndromes, the genes have now been cloned, and therefore chromosome breakage is not your frontline test. It still is for Fanconi anemia because of the fact that there are so many, more than 25 different gene mutations that can give you Fanconi anemia. And the chromosome breakage pattern that you see in Fanconi anemia essentially serves as a functional assay. So for those people who are doing NGS, et cetera, you'll know that there's a large number of variants that are discovered that are of kind of uncertain clinical significance, but they can quickly move into being pathogenic variants if you see that a person who has one known pathogenic variant and one unknown, when you do a chromosome breakage study, it actually shows the classic pattern. The other conventional cytogenetics that was used for a special kind of syndrome, which was Fragile X, where you grew the cells in specific types of folate deficient media. And here is, in this next slide, just an example of the breakage that we see in Fanconi anemia, very specific types of breakage, radial figures, where you have chromatid exchanges that kind of look like spokes on a wheel in response to the bifunctional alkylating agents, DEB and mitomycin C. And Fragile X, you can see that you kind of get unique breakage at the very distal end of the X chromosome at band XQ27.3. And looking for this breakage used to be the way to diagnose Fragile X. But in 1991, the FMR1 gene, which is responsible for Fragile X, was cloned, and the molecular basis, which is a trinucleotide repeat expansion, was revealed. So then molecular assays, Southern blotting, and now PCR, long-range PCR, became the optimal methods for detecting mutations and pre-mutations. And this was the first exit of the test from the cytogenetics lab, transferring it over to molecular. So in the next slide, we thought what we would do is have a little quiz on a little bit of cytogenetic evolution and the department evolution. So we'll look for volunteers to answer this question. So the first question, and you can just raise your hand and Michelle will call on you. So who was the founding director of the Molecular Diagnostics Laboratory at the university? Was it Dr. Furr? Was it myself, Ron McGlennon, Harry Orr, or Barat? Do we have any volunteers?
I'm not seeing any no hands up yet. Oh, Debbie Powell is at the top of our list.
Okay.
Harry Orr.
Excellent, Debbie. One drink at the campus club for you. That is correct. Dr. Orr was the director of the Molecular Diagnostics Laboratory. So the next slide is kind of a sequel, that question to that. Why did Dr. Orr not continue as director of the Molecular Diagnostics Lab? A, he decided to attend a meeting in Capri, Italy, where he could present results on SEA1 rather than sit for the board exam. He preferred to work with mouse cells rather than human. He could not grasp CPT coding, or he was not interested in clinical test development. And I should say that these have been vetted by Dr. Orr, so I would never present them without his consent.
Oh, Chris Holquist jumped to the top of the list.
Okay. Chris.
All of the above.
That's actually a very, I maybe would ask Dr. Orr to comment on that. But that's probably true, except I don't know that he was ever presented with CPT coding. Harry has said correct in the chat. So yes, anyway, that was that was the transfer, and Dr. McGlennon became the director thereafter. So G-banding, or conventional cytogenetics, I think you all know, plays a very major role in hematologic malignancies, involved in the diagnosis and the prognosis of the disease and monitoring disease for progression. We've heard numerous grand rounds on this topic and clinical case conferences, et cetera. What is interesting is that it was G-banding that actually addressed some of the very basic questions of the science regarding these recurring rearrangements. And specifically, if you have a rearrangement or a translocation between two chromosomes, which fusion is the leukemogenic one? So if we take the classic example of a 922 translocation with yield CML, you can see that when you break that chromosome and rejoin it, you have two fusions. On the involved chromosome 9, you have the ABL fusion with BCR, so ABL BCR. And on the chromosome 22 that's involved in the translocation, you have the reciprocal BCR ABL fusion. So there really is no way a priori, and especially during the time when this was discovered, that these fusions were critical to the Philadelphia chromosome for CML. How do you decide which fusion your lab might want to work on to identify what's going on? And the answer actually comes from studying variant cases in these hematologic malignancies. So about 90% of the time, when you have CML, you have a straightforward 922 translocation, as you have here, forming this small chromosome here on the 22, which is what is known as the Philadelphia chromosome. But about 10% of the time, you're going to have a variant Philadelphia chromosome. And this is actually one from last weekend that was a result of Dr. Ranush Tashakori calling us and saying she was concerned about the possibility of a neutrophilic variant of CML, and could we kind of brush the cytogenetics on it. And what we saw when we looked at the G-banding of this case was that there wasn't a straightforward 922, but rather there was a complex four-way rearrangement. 3 went to 22, 22 went back to 9, 9 went to this 22, and then this 22 went back to 3. So if you think about that, what you are not getting in this is the reciprocal of 22 back to 9. You have actually just the 922. And that's how it was figured out, that actually it was BCR ABL rather than ABL BCR that was the leukemogenic part of this translocation. So moving from G-bands, the next technique that has just continued to expand for decades now in the laboratory and in the field is FISH. So FISH provided us with the ability to access cytogenetic events in non-dividing or interphase cells, so cells that were not in mitosis, and to offer rapid diagnosis. In the lab, we use it to diagnose lethal trisomies at birth, so the same day. Sometimes there'll be a baby that's born, an infant, that has very serious congenital anomalies. They're trying to make a decision of whether to go to surgery or not with the baby for a cardiac malformation or other. But if it is a lethal trisomy, 1318, they typically will not go. That decision is made, obviously, with the family and a lot of other support from the physicians and counselors to diagnose an urgent case of leukemia. So this would be a call from somebody in HemPath, Mike Linden, Amy, Sophia, telling us, we think we have an APL, which would need to be known immediately. So we would actually have FISH same day. It can be used to detect deletions and duplications that are too small to be detected by G-banding, to detect cryptic rearrangements, which is a rearrangement that can't be seen by G-banding. And that has actually led to the identification of new categories of hematologic malignancies, and also to be able to custom probes, both for research as well as to validate our findings that we get by array and other techniques. So just as an example, in the classic case of FISH for a typical 922, you're going to have your BCR-ABL fusions. You're going to have two of them, your BCR-ABL and your ABL-BCR. Obviously, we don't know which is which when you're just seeing green and red dots. And then your normal 9 and your normal 22. In the variant case that we just showed, this was the FISH image that we had, and we were able to do this immediately and get a very rapid result. And that is, we only have one fusion here because we only have, in this case, we know it was BCR-ABL because we had our G-bounds. But again, we don't see the second fusion because that 22 did not go back to the 9. We also have FISH probes that are not based on fusions, but rather when you have genes that take many partners or multiple partners, they're so-called break-apart probes. And this is an example with IGH, which does take multiple partners. In these cases, the same gene is kind of labeled on the 5' end and the 3' end in two different colors. So the normal situation here, when the gene is not rearranged, is to be fused, but when it's not rearranged, you would see it as broken apart. And this is invaluable for looking at some of these cancer hematologic malignancies with genes such as KMT2A, previously known as MLL, MLLT10, and NUP98. And then once you find a rearrangement, and in particular, Michelle will be talking about this in myeloma, you can go on and look at specific fusions. In this case, again, a dual fusion probe where you know IGH is rearranged, so you go in and look for the partner by having the potential partner labeled in a different color, the same assay that we used for BCR-ABL. I think the one thing that both Michelle and I feel so strongly about is that participating in national groups, Children's Oncology Group, Alliance, which is the adult group, College of American Pathologists, American College of Medical Genetics, Cancer Genetic Consortium, that participation and participating in a very meaningful way, being really involved in writing guidelines, in reviewing and studies, has been invaluable, not just for our own personal and professional advancement, but for advancing clinical care within the laboratory, because we identify areas for scientific study and for enabling our laboratory to impact national guidelines. And an example of this, there are many examples, but the most recent one actually has been our work with COG, in particular, my work with COG, that led for the first time in the WHO 4th edition, the identification of the category of pediatric AML, kind of differentiating that to some extent from adult AML, because looking at thousands of cases and trials over the last decade, we've come to realize that there are certain translocations that are much more frequent in children than they are in adults. And very interestingly, there's a number of these rearrangements that are specific to infants. And so you don't see them even in older children. And that again gets to the basic science. Do these develop in utero? What are predisposing factors? All of those things that are addressed in biology studies that actually supplement the clinical trials. And the latest trial for AML, I've spoken about this in COG, opened in June of 2020. And in AML right now, there are very few targeted therapies. It's very different from ALL, acute lymphoblastic leukemia, where there now is more of an understanding of the underlying mutations and development of drugs. But I think we heard with Zohar Sachs' talk a few weeks ago about the upcoming types of drugs that are going to be available or now are available for patients who have specific subtypes of AML. So identifying those underlying targetable mutations is really critical for the field. But in the meantime, what's used is risk stratification. So risk stratification is where we know, based on event-free survival curves and also relapse, is which abnormalities are going to be poor players, are going to, in this case, if you have a high-risk finding for a child with AML, they're going to go to transplant after the 4th round of chemotherapy. If you don't have one, you're going to stay with chemotherapy for 4 or 5 rounds. And what we can see is that up here in this chart, we have monosomy 7 and monosomy 5, or loss of 5q. And those were the only 2 high-risk factors that were considered in risk stratification for pediatric AML prior to July of 2020. Now you can see that this list has greatly expanded. All of these now are high risk, and we're seeing almost 40% of those cases go to transplant because of high-risk findings in pediatric AML. In this new trial, we've looked at a little bit over 400 cases. And I want to call your attention to the fact that the ones in red are ones that are cryptic rearrangements. These are ones that you have to have FISH to see because you can't see them by G-banding, and they account for a significant number of the patients on this study, 6% with a KMT2A MLLT10 and 6% with NUP98 rearrangements. In the AML trial, I just think it's a very good example to show how the technologies are merging to make clinical decisions. We have a group of sequenced genes that are being done. This is being done by the French Touch. And then Foundation Medicine that has a whole complete panel of fusions that they're looking at. These fusions, which ones were included, were based on, again, wanting to include all of the high risk as well as those which are known as low risk, for which there are actually only 2, RUNX1, T1, RUNX1, and CBF beta MYH11. We also asked all of the labs to do upfront FISH to identify the 2 good players, as well as the 2 translocations or rearrangements, the genes that are rearranged that we knew are often cryptic. And you'll see that MLLT10 is not on this list because at the beginning of this study, which was just a year ago, we really did not recognize how important that was going to be. But even so, many labs, clinical labs, didn't have NUP98 up and running. They hadn't validated in our lab. And we were able to provide them, actually Molly Lynch and Leanne Oseth, who work in the Cytogenetics Research Core facility that we have, were able to provide them with probe and controls so that they could get their validations done. And then we have Hematologics looking for very specific immunophenotypes that are associated with certain risk. So of the 425 patients that we reviewed, and the review of these data, all of the genetics data are done by myself and Gordana Raka from Children's Hospital in LA. We had 96.5% concordance between the different methodologies and only 3.5% discordance. But very important questions were raised by what causes discordance. And so we looked at specifically what are those abnormalities that cause that either Foundation Medicine is having trouble seeing or that we're having trouble seeing in cytogenetics, be it FISH or other. The inversion 3, which is kind of a subtle abnormality, this is the normal 3 over here, and this is the inverted one, which results in an RPN1 MECOM fusion, which you can see again is, you can see your 2 fusion signals, was one that was missed twice by Foundation Medicine. And if you look at the science of this, the reason for that is that it's not that the fusion actually causes a new gene product or chimeric gene. It's more that what happens is that you alter EBI1 expression and GATA2 expression, because what happens when you have the inversion is that you change the location of the enhancer that normally should be controlling GATA2, but instead what happens is that it, with the inversion, ends up actually influencing EBI1 and causing increased expression of EBI1 which is also what causes which is the leukemogenic driver event in this particular subtype of AML. So the one thing about FISH is that we need to know what to fish for. We needed to know when we got the call from Manouche that she wanted to look for CML with a neutrophilic variant. So we were able to put on BCR-ABL, or a Mike Linden call that says look for APL. So with arrays, which were the next step, we could actually now fish the entire genome without having to have some kind of pre-knowledge about what we were going to fish for. Arrays have become frontline for constitutional genetics, children with especially neurodevelopmental disorders, autism, and new recurrent deletions and duplications have been identified. It's answered basic questions of why deletions or duplications recur in certain regions of the genome, which is due to them being flanked by low copy repeats, which have about 98% homology to each other. And we also began very early on to use arrays upfront in pediatric acute leukemias, and they have proved invaluable in identifying constellations of abnormalities associated with particular subtypes of leukemias. And it has allowed us to put out a report that actually integrates all of the findings from the G-banding FISH and array within the first couple of days after diagnosis. We've identified new mechanisms like chromothripsis and chromoanasynthesis and uniparental disomy and trisomic rescue. So this is an example of a patient here who had a array showed of chromothripsis, which is really a massive kind of catastrophic breakage and rearrangement event. When you looked at this particular, and this is chromosome 5, and you can see how you just continue to delete, go back to normal, delete, go back to normal, delete, normal, et cetera. This occurs in about 15% of AML cases. When we looked at this by G-banding, what we saw was a deleted 5. So it kind of shows you what's behind the scenes, that something that you might call out as being just a straightforward deletion is much more complex and actually has more serious ramifications, as usually it's a poor player. So what we also have learned is that although we tend to think about fusions as having arisen from a simple translocation or a variant translocation, there are many, many mechanisms, and these are really interesting to study from a basic science standpoint of why do these genes have such a need to kind of go through all these acrobatics to fuse to each other. And this is a case that was a patient with T-cell ALL. And one of the probes that was put on was a BCR-ABL. And we didn't see a fusion at all. But what I think is easy for everybody to see is the phenomenal number of copies of ABL1. So we have ABL1 amplification in this case. Again, the probes that we put on were just BCR and ABL. So that's all that we saw from the FISH, this FISH assay. But when we ran an array, what you could see was that there actually was on chromosome 9, which this is a part of chromosome 9, there was a larger region that was amplified. And if you looked at the breakpoints of that region and you saw the genes that were involved, one was ABL1 and the other was NUP214. So by virtue of having amplified this region, what happened is that you cut out this particular region that was flanked by ABL1 and NUP214. It circularizes and it formed an extra chromosomal episome. So it wasn't within the chromosome anymore. And it was a NUP214 ABL1 fusion. So if we had put a probe to NUP214 on that bone marrow sample, we also would have seen amplification of NUP214. So again, this is the way you might say this patient has a NUP214 ABL1 fusion, but you had no idea how it came about. And it's because of asynchronous division that goes on with this fusion that you end up with amplification. Another example of how the arrays have showed us cryptic rearrangements that are important is this is an array on a patient with a BALL that actually has what's now called Philadelphia chromosome negative ALL. And what you can see in this diagram is a small region of loss. It actually occurs in the pseudo-autosomal region, the regions that's shared by the distal end of X and Y. And so you really don't know unless you actually fish onto metaphase chromosomes whether it is X or Y that's involved, if it's a male patient, in which case this was. And again, you have something similar going on to what you had with the amplification case. You have at the boundaries of this are CRLF2 and P2RY8. So when you take out the middle, what you end up with is a fusion of CRLF2 and P2RY8. Again, one of the findings that's linked to pre-B ALL Philadelphia-like. And what we've seen that what really impacts whether or not you have a straightforward translocation or sometimes some very complex form of insertion or rearrangement is actually the orientation of the genes and the way their direction that they're transcribed on their native chromosomes, so that you need to actually have them so that rearrange such that you can have a complete transcript and a functional transcript. And so very frequently, instead of a simple translocation, what you have is an insertion, which will enable the chromosomes and the genes to keep their orientation to have a functional RNA. And I want to show an example of a recent case that we had in COG in the trial that I really feel we brought everything to bear to make the call for this child. This was actually a 3-month-old infant who presented actually at the University of Iowa. And the cytogenetics are sent to myself and Gordana to review. And this is what the institution had called, which was totally accurate. They called the ring chromosome 7. You can see it there, kind of circular. And you can see this abnormal chromosome 12. It's very, very subtle. It was a very good call by Iowa, which they also validated with a probe to 12P involving ETB6, and then a gain of chromosome 19. Foundation medicine results came back as being negative for any kind of ETB6 fusion. This was surprising given that we had a partial deletion of ETB6. And I really felt I knew what this was, again, just because of experience having been involved in so many of these trials and seeing rare cases. Also, this happens to be an abnormality that we studied a while ago, way back with Kathleen Conklin. I asked the University of Iowa if they would be able to run an array, and they were great about doing that. And what you can see, this is chromosome 7 here, is that you have these non-contiguous regions of chromosome gain. And then at the distal end, so the long arm, you actually have no loss and no gain. It's intact. But yet, if you were to look at the G banding and you were to know G banding, you would say, it looks like, I don't know, it should be kind of lost there, but it's not. What I thought was going on was that there was an ETB6 MNX1 fusion, and we can talk about why I thought that, but we had to prove it. Having that specific rearrangement would send this baby to transplant. It would be a high-risk factor as opposed to standard care with chemotherapy. And you can imagine that there was a lot of discussion about this, a lot of emails from the physician. The family was very anxious with a 3-month-old baby. And I would like to just call out Molly Lynch, who is in the research lab, who was able to make a probe to MNX1 very quickly. And then also, along with an ETV6 probe, Iowa sent us material and we probed it. And we were able to see is that this is your normal chromosome 12. This is the abnormal chromosome 12 here. and it has lost part of the ETB6. And if you look at the same chromosome, which we then stripped and rehived with the MNX1 probe, that actually it co-localizes. So this was actually really supportive of the presence of an ETB6 MNX1 fusion, and that's the way that this baby was stratified. So why was it in particular that I really felt it was an ETB6 MNX1? One is because of the really interesting associations that occur between primary and secondary abnormalities in leukemia. We still do not know why. And this is a question that would be great to have a research conference on and see what the basic scientists can come up with. But we know it exists. We also know that there's mutations that are associated. But if you look at the first one in this list, you'll see that the translocation 712 or the rearrangement is associated with a gain of chromosome 19. And if you go back to this, you can see that we had the gain of 19, we had an abnormality of 7, we had an abnormality of 12, and we had an infant. And if you remember the slides a number back, that actually showed us that the 712 is one of those rearrangements that is found specifically in infancy. So one of the things that we did as a first collaborative study with Children's Hospital Pennsylvania, Cincinnati, ARUP, and ourselves was actually, and this was Linda Baum's work when she was a fellow here, to actually put these data together, merging the copy number gain, the copy number with the fusion, and creating a Circos diagram so that we could see these copy number along with the fusions. So we're up to our next question. The University of Minnesota Cytogenetics lab was the first in the state to offer chromosomal microarray testing. This happened because A, microarray technology was developed in the Biomedical Engineering Center at the U of M. Other cytogenetic laboratories in the state were late adopters. Dr. Leo Firk had the foresight to see that this technology was game-changing and wrote the check, where insurance companies immediately came online to reimburse for CMA testing. Volunteer?
Not seeing any hands yet.
There's chats. I don't know if that's the.
Oh, there are some chat. Yes, we do have some chat answers. C seems to be the winning answer here.
Okay, and C is the answer. So Dr. Firk actually did make a trip to look at the first arrays that were coming out in Texas, and he did write the check to be able to allow us to have that technology in the laboratory. And we learned a tremendous amount from those first arrays, and then now have run probably close to 10,000 arrays. It's an extraordinarily popular test. So what next? The next technology coming online in many cytogenetic laboratories is optical genome mapping. It's based on isolation and labeling of high molecular weight DNA. It allows genome-wide high resolution detection of balanced and unbalanced structural rearrangements, as well as copy number. And that's something that array doesn't do. It doesn't allow us to see balanced rearrangements. So it's basically giving us all in one the information of balanced that we could have gotten from G-banding fish and or chromosomal microarrays. And this is an example, and you can see this Circos diagram, which is how this data comes out, is very, very similar. This is an ETB6 RUNX1 case. Linda Baum's that we presented before was an ETB6 RUNX1 case, except that we had to put the pieces together ourselves to get the Circos diagram. Here, this one technique is doing it all at once. And what you can see is that in addition to having the ETB6 RUNX1, which is caused by a 1221, the optical genome mapping, which in this case was BioNano, also identified several other fusions that we really at this point don't know what the significance of those are. And this is an example from my colleague, Gordana Rocca at Children's Hospital in LA, where they have already validated this. And this was a case that was normal by cytogenetics. The copy numbers in the outer range. And again, you can see all of the rearrangements. She was able, again, being able to interpret this and knowing the translocations to know that this was an MEF2D Fox J2 rearrangement. But you can see the complexity of these that you're going to get with this type of technology. But you're going to have to go and sort through and figure out which of these fusions are significant, which is not. This is actually no different than what we faced when we actually brought on arrays, when we were seeing a lot of copy number variants of unknown clinical significance. We actually just built our database over time. We also figured out a way to strip arrays and then be able to run parental arrays on the same chip. So we weren't using any, we didn't need to have the cost. We were able to do it free of charge. And we built our databases now such that we've had thousands of these variants that basically are taken out completely from when we actually do the analysis. We never have to worry about them. And we actually have made a track in the UCSC for these tracks. So with that, I'm going to turn this over to Dr. Dolan.
So anyone who knows me or has ever visited my office knows that Marie Kondo and Michelle Dolan do not typically go together in the same sentence because I am not usually one to discard things. However, and typically also we think of discarding things in the Marie Kondo sense as discarding physical things, stuff. But how can we apply that to the fact that we now have multiple technologies, some of which determine, or some of which will answer questions, but in different ways, some of which may yield the same answers. Some have much higher resolution than others. Some offer other benefits such as speed or sensitivity. So how do we choose those? Do we do everything all at once? Do we discard, so to speak, certain ones? Do we simply take on the newest test and assume that that is going to be the new be all and end all? So how and what can we discard? So really, before we even start to answer this question, we really have to evaluate data that's been collected over time to determine what's really needed for patient care. It's not really responsible to just say, okay, we now have, microarray or optical genome mapping, go with that. So we'll take as an example our workup for plasma cell neoplasms. And we do get a lot of plasma cell neoplasms here at the university, and our colleagues in Heme can certainly attest to that. We do kind of a two-pronged test. One is with FISH on plasma cell enriched bone marrow. And we plasma cell enrich for plasma cells to increase our yield. And it's been very, very helpful in that regard. And we also do G-banding. Now, to further drill down in one of those two prongs, i.e. the FISH, we use a specific panel of 5 different probes. And each of these probes is chosen because it provides different prognostic information. And so what's interesting here is that when you look at these different probes, one of which is looking for both loss of 1P or gain of 1Q, the next probe looking for the trisomies of odd-numbered chromosomes that are frequently seen in myeloma, next looking for loss of chromosome 13, either all or part of 13, next probe looking for loss of TP53, and then we use an IGH break-apart probe. So what's interesting in this is out of all of this probe data, we can zero in on 5 high-risk features that really answer the questions that the clinician needs. So we can ask ourselves, well, if they have the data that they need from FISH, do they really need G-banding? So what is G-banding like for us? Well, oftentimes they yield really complex karyotypes. So I'm just going to show 2 complex karyotypes, one more so than the other. So this, I'm going to focus on the derivative 14 from an 1114. This much more complex karyogram also showing IGH rearrangement. So each of these two karyotypes, really what they're providing information on is a lot of other information, but really what we needed to know was the IGH partner in this particular case. So really, G-banding is something that is not particularly helpful, and it's very time and labor intensive in the setting of plasma cell myeloma specifically. We also need to evaluate carefully the strengths and limitations of each method for individual cases based on the clinical indication, the reason for referral. So in this particular case, this is a constitutional case. Reason for referral would be, very, very broad. But what we're seeing here by microarray is a gain of the distal long arm of chromosome 2. You can see this very sharp demarcation where you've got gain of this region extending down to the telomere. So from 2q34 to the telomere, encompassing about 340 genes. We also saw a deletion within distal 6p, also extending to the telomere. So we have a concomitant loss of 6p and gain of 2q. That, until proven otherwise, is representative of an unbalanced translocation. But to prove that, we really do need to see the G-banded karyogram. And that does indeed show that we do have an unbalanced translocation with a derivative chromosome 6, and this is material from distal 2q that's replacing 6p. So what's important here is that, yes, indeed, we really do need G-bands in this case to really understand the mechanism of what we saw by microarray. This is also very important from a counseling standpoint. As Betsy mentioned earlier, these abnormalities do affect families. It's not just that you're making the diagnosis for the patient. And so it may well be that one of the parents might carry the balanced form of this translocation, which will obviously have great ramifications for risk in the future. And also trisomy 21, this image should look familiar. It was presented earlier in the talk. If we were to have done FISH, as Betsy mentioned earlier, one of the benefits of FISH is rapid turnaround time. We can get a FISH for trisomy 21 turned around in either same day or next day. If we have a diagnosis by FISH of trisomy 21, we need to be able to see the G-bands to understand the mechanism. Because yes, even though most cases are going to be a non-disjunction trisomy 21, you have to be able to recognize the Robertsonians. And really, G-banding is the only technology that we've discussed thus far that would be able to detect that Robertsonian, which really does have, again, significant genetic counseling ramifications. So yes, particularly for constitutional, G-bands will be continue to be necessary. Arrays cannot detect balanced rearrangements, and as Betsy just presented, optical genome mapping may be able to do so. But really what's kind of a testament also to how we approached cases, array data, and merging with G-banding is that typically these would have been approached in a lab as you do the microarray separate from the G-banding. And for a G-banded study, you typically need to analyze 20 cells and provide 2 karyograms. But really what we're looking for, if you have a normal microarray study, really what you're trying to do by looking at the G-bands is rule out a balanced rearrangement. So do you need to look at 20 cells for that? Not really. And so our lab took the innovative approach at the time, one of the first in the country to really develop this approach, which is to take an existing CPT code, kind of hiding in plain sight, which allows us to do a limited study of only 5 cells rather than 20, yet paradoxically resulted in increased reimbursement for that. So now this is a merged test. They're not standalones, but it's a microarray with a limited G that does makes for streamlined testing and also enables us to follow CPT codes, because that is critical, obviously, as well. Now, in cancer, a different approach is indicated. particularly because complex cases are very time and labor intensive. So for example, if a technologist is looking at this under the microscope, they pretty much know that they have the abnormality right there. And they really don't need to look at 20 cells to be able to know what the clone is. One of the issues is it takes a lot of time and effort to get from looking at this metaphase spread to looking at this karyogram. So can we take a similar approach and use an existing CPT code, or can we be creative and come up with new CPT codes or advocate for new CPT codes such that we will be able to streamline such time and labor intensive cases? So particularly for cancer, the future will look different than it looks now, certainly. Likely in the not too distant future that conventional cytogenetics will not be used for ALL, and probably shortly thereafter for AML as well, largely due to the identification of actionable targets that can be identified by molecular. Also, diagnosis, as we talked about with plasma cell neoplasms, diagnosis and risk stratification can be detected by FISH. It's very similar for solid tumors as well. We will, however, continue to need FISH also because of its increased sensitivity, its speed, its rapid turnaround time. We'll need it for follow-up cases, again, the increased sensitivity, as well as for minimal residual disease testing. So kind of to bring this full circle, we started with discussion of non-banded chromosomes, very early days of cytogenetics, and showed a non-banded chromosome with detection of the fragile X site. This can also be detected by optical genome mapping. Now, there's some caveats to that in terms of the size of the mutation and the trinucleotide repeat that needs to be present to be detected, but still, there are very rapid advances being made in optical genome technology to be able to detect not only the known cancer rearrangements, but also constitutional rearrangements as well. So what I think this talk has shown is that there really is no perfect wheel yet, but we are at a state-of-the-art wheel with the optical genome mapping. It's a very exciting time in cytogenetics, and I think it's a great segue into our future. We would at this point like to acknowledge the fact that we work with great colleagues. We have great technologists in our lab. They are very highly trained, and to do those time-intensive complex cases requires a lot of experience. And we're very fortunate in that regard. Also, all our colleagues in the Department of Lab Med and Path, we are so fortunate to really have such great colleagues who we interact with frequently, and there's no barriers to interactions with any of our colleagues. And also we would like to recognize certainly our colleagues from COG, CAP, and the CGC. One thing I did mention or want to mention earlier was that a lot of these interactions that we have with our committee members really does drive how we practice here. And it really is so personally and professionally rewarding as well. So we would like to open this up for discussion. Ideally, we'd like to hear from colleagues with, again, this was kind of a different approach and kind of existential in a way to really take a look at the field and say, what does our future look like?
And I just want to add that Dr. Burke has written another check. And so I think it's a great thing that the optical genome mapping will be going into for research purposes right now, and with Dr. Sen taking a lead on that with Sophia Yohe. So again, I think that we are very fortunate in being in a very collaborative environment and sharing all the knowledge that we have right now about these variants of unknown clinical significance, what we've learned about them, transferring them over. Molecular has their own from the NGS data. But again, I think that this type of moving forward really needs collaboration, and not just between the labs, but also with the providers. We have to get them on board and explain to them why we want to change, let's say, not doing G-banding for myeloma, even though that's what they were trained in as they came through their own training history. So we would very much welcome.
Yep. Tony has his hand up.
Okay.
Hi, thank you both. That was a great presentation. I have a question sort of to Michelle's final point. What is the supply pipeline like for both doctoral level cytogeneticists as well as medical technologists?
It's a trickle these days, and that is nationally. It's almost a crisis level in a lot of ways, where certainly what we're seeing in our lab is due to closure of a number of formerly, flourishing cytogenetics training programs. Really, we're not attracting, they're not available, trained cytogenetic technologists. And so we're having to do a lot of that training from the ground up, and that's very time intensive.
So how, you raised the word existential. How is that likely to impact the field?
There's a lot of ongoing discussion about that at the national level. In fact, there was just a national meeting of the American Cytogenetics Conference where they're starting to address whether there are actions that we can take. Some of those might be in terms of outside training programs. Some may be looking at benefits and salaries that and room for advancement that technologists might have in their positions. Because in some places, really, they're a lab tech and there's not much room for advancement. So I think we have to look at a lot of the outside things that we haven't typically thought of previously in terms of making this an attractive position.
Okay, thanks.
Scott?
Thanks for a really exciting presentation. I'm really interested in the optical genome mapping. We recently sent some tissues to Bionanogenomics on a fee-for-service basis to do this. It's my understanding that there are some, technical limitations with this technique requiring fresh tissue of high quality so that really high molecular weight genomic DNA can be isolated that's suitable for this technique. So can you just comment on the experiences that you've had with this optical genomic mapping and the types of tissues in which you've used as input? Does it always have to be fresh tissue? Have you used anything archival or tested anything in that regard? Have you tested solid tumor tissues or really focused on liquid tumors for this technique? I'm just interested in your experience and the applicability.
So, Scott, this is Betsy. For some reason, our video is in here. Sorry to be a black box. But so first of all, we do not have any experience with our own hands on that technique. However, colleagues do. And actually, Gordana and I have a project that will be funded actually to look at some 60 cases actually from COG that have these very interesting rearrangements. But with respect to your question, the only tissues that are right now that you can use are either fresh tissue or frozen tissue. So you can do it with frozen cells, but the fact is they have, their proprietary isolation, because the way that it works actually is to get this long sequence DNA. They then kind of put in a 6 base pair mirror that's labeled, that actually is what ends up being incorporated and gives you this high resolution, almost kind of like, banding pattern that labels it. But right now you can't use it on fixed tissue. You can't use it on paraffin embedded. So you're totally right. It's limited right now. I know that they are working hard. I've also asked them about mouse because from a standpoint of bringing it into the core, and they have some advancement in mouse, but not enough. They will be also adding some sequencing, hopefully. But I think the next big step is you don't need very much. That's the one good thing. You don't need a big specimen, a lot of volume, but you do have to have either fresh or frozen tissue. And it also has to be, I know that Gordana, who's the person that I've worked the most closely with who has it, and Bryn Levy from Columbia, have said that you really can't go back to like archive specimens very well from even fixed the methanol acetic acid, that you just need high quality DNA.
And if I could ask one more follow-up question. So for somebody like me, for research interests that would be wanting to transition from sending tissues to the company to doing it here, what are the logistical steps for doing that?
So Scott, I can say that we just got the instrument installed last week.
Okay, so pretty fresh.
So we're not, I don't think our institution is at a point yet to do this. So yeah, so I have an IRB study for the instrument right now, and we have the instrument for about 6 months to do that study, and it's unclear exactly what's going to happen after that, and we're still working on that. So that's not really an option at this point. And then just another detail, like the DNA fragments need to be about 100 kb. So that's the limitation with fixed tissue, is that you just get too much fragmentation of the DNA and you don't have those long DNA fragments. So, yeah.
But I think we do have colleagues, Scott, if you had an immediate need, but if it's a big study, then that's different, I think. The way that BioNano often works is also, you don't necessarily have to buy the instrument outright. You can just buy reagents and do it on a rental basis. I think they're going to move pretty quickly. And I have I can send you a couple of presentations that was a symposium in January, because we put our that research thing in kind of a year ago. So anyway, we can follow up, but it's a work in progress, and it's going to be great that it's in molecular diagnostics here, that thing, or in the research part of molecular diagnostics. So I think we can keep you posted.
Great.
Betsy, Leo here. Did you have follow-ups?
No, just a thank you.
Okay. Betsy, Leo here. Hey, thank you, Michelle. This was an excellent presentation. Just on the last topic, like other things, well, maybe to step back for 1 second for both the residents and the faculty, you can't always wait for the hospital to get you what you need, or the institution. So you have to reach out and use your best judgment when you see these emerging technologies, sort of grab the brass ring and put it in the hands of really good and smart people, like we've done with these things. And you just never can imagine how far it might go. On the latter point that Scott and Sophia were raising, we're early in the game in this, but if this becomes a fundamentally enabling technology, we can look at setting up something like we've done with bioinformatics or whatever, where we develop a core service or something like that. It's there. But, we're still, working on unboxing the machine figuratively and getting our hands around it. But anyway, this is a wonderful talk. If there's a minute, I don't know if there is, to either of you, Betsy or Michelle. I keep seeing things about how much we should be doing germline assessments in, malignancies of whatever sort. Can you give just a brief snapshot of what the thinking is on that?
I'm sorry, Lee, I didn't, you might have cut out right at, could you just repeat the question, please? I'm sorry, I missed it.
Yeah, so the question is the current status of thinking relative to germline testing in malignancies.
So I may
Too long an answer?
So it's becoming incredibly important for the hematologic malignancies. The overlap between, especially in the pediatrics, as you might imagine, but there are several places that have large panels now in place for doing germline susceptibility. There's also most of the places that are doing tumor cytogenetics. I know, for example, LA Kids and others, and Cincinnati, who have these panels, and Chicago, are running germline DNA that would not be expected to be involved in the malignancy alongside of the tumor tissue. And that's probably the best way, actually, to get at it. One of the, just kind of anecdotally, through the COG study, we had a patient who had a +21 as the sole abnormality in the AML clone. And it also had mutation, which goes along with trisomy 21. The child had absolutely zero findings of Down syndrome, and yet we did pursue it and found that it was constitutional, that it was germline. So you have everything. Most of them, I mean, we had a case, Sophia, you might, I'm sure probably know it, last week, that essentially the patient had AML, grandfather died of CMML, and the patient had a partial deletion, just 3 exons in RUNX1. So I think you need to be thinking about this. I think right now, the clinical trials are looking at whether or not any of these, let's say if you have a germline, does that affect what treatment you would get? Does that increase your risk? Does that make you just the same as anyone else who has AML, regardless of whether you have an ETV6 deletion or not? These are really important questions. There's a lot of dialogue on it, but nobody has the answer. But I think germline testing, these are another 2 kind of Venn diagrams that now are overlapping. You used to have, maybe you had Fanconi, but then you had a totally separate cancer-acquired genetics. Now those Venn diagrams are overlapping. So it's a really important question that you've raised.
Thank you. Thanks again for the.
Okay, we are going to sign off for summer break. Thank you all for joining us. Have a good summer. Stay healthy and stay safe. Thank you.
Thank you.
Thank you, Amy.